Hi everyone, and welcome to this Praxis Spinal Cord Institute webinar today about what is happening with spinal cord injury data and how that data supports research and changes in care in Canada. I know just as everyone's joining, just wanted to give a few housekeeping updates. So you'll have seen we're recording this meeting and it'll be available afterwards. And also we're able to provide captions in different languages, including French. So if that's of interest to you, please, you need to go and enable captions through the settings and choose the language that you would like to see. And if you have any issues with this, you can put a question in the chat and Sam, who is our project coordinator, will be able to help you out with this. We have quite a packed agenda today, so we'd like to ask if you have any questions that you could either put them in the chat and we'll try and answer them as we go along. And also at the end of the meeting, we will provide an email address that you can contact us on, and we'll try and summarize any of the questions and answers that we haven't been able to get to. So thank you very much for that. So here's a quick summary of what we'd like to cover today. I'd like to start by acknowledging that the Praxis Spinal Cord Institute, and where I'm calling in from today, in Vancouver, sits on the traditional and unceded lands of the Squamish, Musqueam, and Tsleil-Waututh First Nations, and I'd like to encourage everyone calling in today to reflect on where they're calling in from. So we'd like to start with a bit of a background of Praxis and the Rick Hansen Spinal Cord Injury Registry. And then we'll go into a few more details about different projects and activities that sit under RHSCIR, or the registry, and also finish off with some future directions for the registry in the next few years. And there's a few of us from Praxis talking today, and we'll introduce ourselves as we go along. And also like to introduce Dr. Colleen O'Connell, who's the medical director and a physiatrist at the Stan Cassidy Centre for Rehabilitation in Fredericton, New Brunswick, which is also a RHSCIR site. And to start off, my name is Suzanne Humphreys. I'm the Associate Director of Data Services at Praxis, and I look after our research data assets and run the day-to-day operations of the Rick Hansen Spinal Cord Injury Registry. So some of you on the call will know who Praxis is, for those of you that don't. Praxis is a Canadian-based non-profit organisation, and we're headquartered in Vancouver. And we lead an international network of people with spinal cord injury and other world-class experts who work together to identify, prioritise, and work on the most urgent challenges in spinal cord injury. And this allows us to move the most promising ideas from conception into best practice in care, or into the marketplace and into the hands of people that need it. We have a very bold vision, which is to reach a world with no paralysis after spinal cord injury. And our mission to reach that vision includes leading collaboration to identify, prioritise, validate and accelerate evidence into best practice to reduce the severity and incidence of paralysis after spinal cord injury, to also improve healthcare outcomes and reduce costs, and ultimately improve the lives of those living with spinal cord injury. And here are our headquarters at the Blusson Spinal Cord Centre in Vancouver. It's quite an innovative building where both researchers, clinicians, and those living with spinal cord injury are integrated together. And a nice sunny view from the office, which actually it is sunny today in Vancouver. So how do we operationalize our mission? We do it through our 4 core programs, and that encompasses cure, care, commercialization, and plex, or people with lived experience. And the cure program is based around generating evidence and improving or generating treatments. And the care program is really about creating best practices, maximizing recovery, and reducing secondary complications after spinal cord injury. Our commercialization program accelerates innovations and brings them to the marketplace. And our PLEX, or People with Lived Experience program, is really threaded through everything we do at Praxis and involves the leadership and full participation of people with spinal cord injury in spinal cord injury research and other activities. So really today we collect data under a number of our programs, but we really wanted to focus under the CARE program and specifically on the Rick Hansen Spinal Cord Injury Registry, or RHSCIR. And RHSCIR is a prospective observational study, and that means we're collecting data on a going forwards basis, and that there are no specific interventions or treatments. We are rather recording the current state as people are injured and travel through the healthcare system. And RHSCIR was started in Vancouver back in 2004, initially collecting data on people with new traumatic spinal cord injuries, and more recently branching out to collect data also on those with non-traumatic spinal cord injuries. And over the years, the registry was rolled out across the country, and after about 10 years, we had established registry sites at 30 participating hospitals across Canada that see and treat people with spinal cord injury, both in acute and rehabilitation care. And we're represented in 9 of the 10 provinces. People from PEI and the territories tend to get treated in the other provinces in Canada. We now have over 11,000 participants in the registry, which for a spinal cord injury database is really quite a large number of people. When RHSCIR was established, the initial goals were to create this pan-Canadian database collecting data on spinal cord injury. And the reason being that back in 2004, not so much was known about spinal cord injury in Canada in terms of how many people were experiencing it or living with it, and also how the different hospitals across the country were treating people with spinal cord injury. There was also no pan-Canadian connected network. And so a secondary goal was to create a network to link researchers, clinicians, and people with SCI to be able to facilitate clinical research. And the establishment of this now quite mature network has been one of the high points of running the registry. We also wanted to facilitate evidence and best practice into clinical care, and we have been able to use the registry to monitor this implementation. So what data is collected under RHSCIR? So we collect data in different ways. There is a coordinator at each hospital site across the country, and these coordinators will extract data from hospital databases, medical records, and also data can be provided by the individuals participating in the registry themselves through questionnaires and interviews. For those with traumatic spinal cord injury, we collect data from the point of injury through the journey to hospital, all throughout the first inpatient stay, and then once in the community as well through questionnaires. In 2020, we made a big update to the registry, and we started to incorporate data on people who'd experienced non-traumatic spinal cord injuries. And for those people, we just collect data during their initial rehabilitation stay to start to understand the population, which the numbers of people with non-traumatic spinal cord injury equal or actually are larger than those with traumatic spinal cord injury, and also to help our sites and in being able to report back to them on all the people that they see with spinal cord injury. So the types of data that we collect include demographic information such as age, sex, and where people are living and working prior to their injury, as well as medical history. We want to collect details of someone's injury or non-traumatic cause, and then also we track how they reach hospital. Once they're in their first inpatient stay, we collect data about that stay and how long it was, their diagnosis, their injury severity and level, and how that might change, any treatments that have been received, and if someone is experiencing any secondary complications such as pressure injuries or urinary tract infections, for example. We also collect data that describe how people can function in day-to-day activities, and also how their quality of life is. Once in the community, we repeat the collection of some of this information and add some other questions, especially related to how people have been accessing the healthcare system once they've returned home. So I know a number of people on the call may have participated in RHSCIR, and we just really wanted to say thank you so much for your participation and the time and the contributions that you've made. And without that data that you've contributed, we would not be able to do a lot of the work that we're doing and that we're presenting to you today. So thank you very much. And on that note, I would like to hand over to Sam Douglas, who works at Praxis and is also a participant in the RHSCIR registry.
Thank you, Suzanne. Thank you for letting me share a few of my own insights into RHSCIR. For me personally, being part of RHSCIR, it's about helping others. And if it's okay, I'll explain what I mean by giving some further background into my own injury with some pre-prepared thoughts. So I was injured nearly 6 years ago, back in March 2017, as a result of a workplace accident in downtown Vancouver. I fell almost 30 feet and broke my neck at C5 after landing on concrete. Sorry about that. I was taken directly to VGH and diagnosed with a burst fracture. I underwent decompression surgery in under 24 hours. And following that, I spent 2 weeks in ICU, followed by about a month in the VGH spine unit. After that, I was admitted to GF Strong about a month and a half after my accident. Only after I entered GF did I begin to see improvements in my function. So when I entered GF, I was in Asia B. And by the time I was discharged from GF Strong, about 6 months after my accident, I was in Asia D. And I could, by the time I was discharged, could move my hands again, no longer relied on catheters or a strict bowel regime, and could also ambulate with a single point cane. But it's important to note that I'm not fully recovered. The left side of my body is a lot more functional than my right. And also when I fall, I have extreme difficulty getting up due to my very limited tricep function. So during my time at GF Strong, it was apparent that not everybody was experiencing the same level of recovery as me. But I've also heard some rare stories of people who have had much larger recoveries than mine. And for me personally, that right there, sorry, just had to mute for a sec. My dog is going a bit crazy. But that right there, for me, is why the registry is so important. By collecting data from the moment somebody is admitted with an SCI and following them until discharge. But then
Sam, I think you're still on mute.
No, I can hear Sam.
By collecting data from the moment someone is admitted with an SCI until discharge, but then to regularly follow up with that individual once they're back in the community, we are able to take a snapshot of how SCI occurs across Canada. This helps us to improve upon clinical best practices, as we can use the data to validate how intervention, such as early decompression surgery, correlates with improved outcomes for motor, sensory, and autonomic function. And together, this hopefully translates into improved quality of life for people who sustain spinal cord injuries. Thanks for having me today. And sorry for the interruptions.
Thanks very much, Sam. It was great to have you. Now we'd like to move on and to the project showcase section and really just talk about some of the outputs and impacts from RHSCIR data over the years. So in this diagram, we just wanted to show all the different types of uses of RHSCIR data that there can be. And so we regularly produce different types of reports from the registry data once that we have cleaned it and done some data management at Praxis. And we can use these reports both for awareness and advocacy, and also site level reports that we can feed back to the sites to support them in their implementation of best practices, and also understanding the types of individuals with spinal cord injury that they're treating. We also have a data access process for anybody to request access to the data to answer research questions. And we also collaborate and facilitate working groups of clinicians, researchers, and those with spinal cord injury to work on these research questions, which can usually end up with a scientific publication being produced. Some of the findings from these scientific publications can then be used and translated into developing tools to help clinicians in their day-to-day practice. And we'll be talking a bit about all of these on the next few slides. I mentioned earlier that Praxis has a commercialization program, and we can support this program by using the RHSCIR data to educate, and then also support some company questions related to baseline information about spinal cord injury. So let's go into a little bit more detail about some of those activities. So relating to publications, we have a number of publications each year coming from the RHSCIR data, and these can often be centered around looking at outcomes or treatments or specific populations within the spinal cord injury population. So for example, in the past, we've had a research paper looking at the effect of an older age on the treatment decision after spinal cord injury, and also had a group that looked into the effect of the time between when you're injured and when surgery is performed on your outcomes. And this actually related to a recommendation in change of practice. You'll see a link at the bottom left-hand corner of the slide, and that's to our website where our publication archive is stored. We quite often publish high-level summaries of the important publications coming out of RHSCIR, so that in a snapshot you can understand and read about what are the key findings from each paper. So some examples here, as you can see, we looked at factors associated with recovery, and then also had a group looking into the effects of having multiple health conditions at the same time and how this impacted on people's functions and life satisfaction after an injury. Some of our projects also use more advanced analytic techniques such as machine learning, which is a data-driven approach to develop new patterns and predictions from the data. As I mentioned before, we have a commercialization program at Praxis, and this has 3 parts to it. The ideation challenge, which is really about generating ideas and early innovations. The incubate program, where we support companies that are in an early stage of product development. And the accelerate program, where we are supporting companies who are further along in their product development and would already have a prototype of a drug or a device that can be used for those with spinal cord injury. And we can use RHSCIR data to support the program in different ways. We quite often create presentations for education and awareness purposes, and work with the companies on understanding what living with a spinal cord injury looks like and how people move throughout the healthcare system. And then we have a clinical team and our people with lived experience team at Praxis who will work with the companies to make sure that their products are really going to meet the needs of people with spinal cord injury. The RHSCIR data can also be used to highlight areas of need or focus, such as reducing secondary complications. And another way that we can use the RHSCIR data to support commercialization of products is through helping out with clinical trial planning. So with any new drug or device that's being developed, or medical device specifically, need to go through a series of clinical studies before they are approved for use. And so some of the common issues with designing clinical trials can be understanding what the population that this product is supposed to benefit will look like, especially without an intervention. How do people recover naturally? How many people do you need in your study to make sure that you're going to have a successful outcome? And you may not know which hospital sites you could approach that would be equipped or would have the right kind of people with spinal cord injuries to take part in your study. And you also might want to know what exactly could you measure to make sure that you're going to have a successful study and that your product is going to have an impact. And specifically with spinal cord injury, a particular issue is actually quite a small population, and people look quite different in terms of how their injury presents and how their outcomes will be. And so that often means you need quite a big sample or a number of people to enter your study in order to get a meaningful outcome. And some of the solutions that can be offered through utilizing the RHSCIR data would be presenting some of the baseline information for the population so that it can be understood what the general outcomes are for different types of injuries. And we can use statistical techniques to help determine what sample size should be used or how many people should be included in a clinical study. And then by collaborating with our Canadian registry network, we can help with site selection and which sites may want to participate in certain studies. We can also give advice on what kind of data should be collected to measure changes and show impact with the device or drug that's being tested. And with that, I'll hand over to Chris Walden.
Thanks, Suzanne. I am Chris Walden. I'm a physiotherapist by background. I've been working in the area of spinal cord injury for just over 20 years. And I work for Praxis as a national clinical liaison. So I want to talk to you guys a bit more about some of the other areas where we use RHSCIR data. To start with, in terms of education and advocacy tools, the RHSCIR data from across Canada is made publicly available in a series of reports, and the reports are all freely available on the Praxis website. One of these reports that you see on the screen there is the annual report. This comes out annually, and it includes a summary of information about who's having spinal cord injuries in Canada, what types of injuries they're having, what types of treatments and outcomes they're getting. And so what you see on the screen here is just a snapshot of information from the 2020 annual report. And in the graph on the top left there, you can see that in 2020, the majority of those having traumatic spinal cord injury were caused by falls. More interestingly, if you look to the bottom there, where you can see the yellow figures, we can see that the average age for those having falls was 63 years old. And the average age for those getting traumatic spinal cord injuries from transport or a car accident or that type of thing is 46. So this is just an example of some of the things that are included in the annual report. And information like this can be really useful to inform things like prevention efforts, to let people know where to target those specific types of interventions to different populations. If you look at the graph on the top right there, that's basically just showing that in 2020, the majority of people were having their spinal cord injuries, traumatic spinal cord injuries were happening in their cervical spine, so the region of the neck, and that those were largely incomplete injuries. This basically means that people still had motor and sensation messages traveling down to the bottom of their spinal cord. Next. So we also looked at the non-traumatic, what's happening in terms of non-traumatic injuries. And like Suzanne said, this is a new addition to the registry. So this just reflects some of the centers across Canada, and it only reflects those going to inpatient rehab. But we can use this type of report to look at how people are having traumatic spinal or non-traumatic spinal cord injuries, sorry. And you can see there that the large amount of non-traumatic injuries are being caused by degenerative disease, which is often age-related spine changes. Another way we can use these annual reports is by looking at them over time to track changes that are happening in spinal cord injury over time here in Canada. So this table just shows you a comparison of the information from 2004 to 2020. And it lets us really see that Those individuals having traumatic spinal cord injuries have really, the average age has really increased. Whereas in 2004, largely injuries were due to transport type injuries. Now, like we talked about, mostly they're due to falls. The other thing that we can see in terms of change over time is that in 2004, a large number of people were having what we call complete injuries. And that's where none of those motor or sensory messages were able to travel to the lowest level of their spinal cord. And you can see that in 2020, there's far less people having complete injuries. Another type of report that comes out of the registry, and again, freely available on the Praxis website, is the community follow-up report. So this is a report that looks at what's happening for people 5 years after their traumatic spinal cord injury. And so this one was published in 2017. And you can see there some of the key findings from the report, really just showing where there are still gaps for people after their spinal cord injuries. And so this type of information coming from RHSCIR is really important because it can be used to give concrete evidence for different community SCI organizations or people advocating, looking to fill the gaps that people with spinal cord injury are experiencing in the community. Another type of tool that the registry supports are clinical tools. And so these are tools for clinicians who are working with individuals with spinal cord injury. On the left there, you can see something called the SCI algorithm. So SCI, you may have heard this called the Asia exam, is really a test of the strength and sensation that someone has after their spinal cord injury. And that test is used to determine the level and the severity of their injury. Often people think about their injury level as the level in the back, in their back that they broke bones. But this exam really determines what level in the spinal cord the injury is at. And that can be different from the level where their bony injury occurred. So this exam and this classification has a lot of different rules on how to use those strength and sensation scores to determine someone's level of injury or severity of injury. And so at Praxis, we developed a computer algorithm that could really help clinicians correctly determine that level and severity of injury using this exam. And RHSCIR data was essential in validating this tool. On the right, you can see something called ambulation. And this one is a tool for clinicians that uses research done using the RHSCIR data. And what it does is provides clinicians early on after a patient's spinal cord injury with an idea of the likelihood that that individual will be able to walk without help from another person 1 year after their injury. And so a tool like this is important because it can be used to inform clinical treatment plans and help support education to people with spinal cord injury after their injuries. Another area that RHSCIR helps support is the implementation of best practices, like Suzanne mentioned. So Praxis also supports projects for clinicians to start to regularly use measurement tools that allow them to track changes in their patients or clients with spinal cord injury over time. And so 3 of the tools that are best practice to use are the SCI, which we just talked about a bit, the Spinal Cord Independence Measure, or SCIM, and the Standing and Walking Assessment Tool. So SCI, we talked a bit about. This is really the gold standard internationally for being able to assess neurological impairment, so impairment to an individual's spinal cord after their injury. And it's used to determine the level and severity of the injury to their cord. This is collected in RHSCIR, both when somebody's in acute care and also when they're in rehab. The Spinal Cord Independence Measure, that's a measure that really assesses a person's ability to do different activities of daily living. So dressing, eating, or bathing. that type of thing. And it looks at how independent they're able to be in all of those tasks. It captures the changes in a patient's functional abilities between admission and discharge, especially when they're in rehabilitation. And it can really help guide what kinds of care and help plan for what kinds of care a person needs after discharge. It's an often used tool to assess the impact of how different clinical treatments or therapies are impacting a person's ability to do different functional tasks. And it's used both in hospitals and in research studies. And so this one is collected at inpatient rehab. The SWOT, or Standing and Walking Assessment Tool, this is a tool that was actually developed here in Canada by a group of physiotherapists and researchers. And it really provides a standardized way to track standing and walking abilities and progress during inpatient rehab. And this one helps, it can help to guide therapists and patients in developing their mobility related goals during inpatient rehab as well as treatments. So how does RHSCIR support these projects? The registry and collecting all of the information collected by clinicians and having that in the registry really supports us to be able to feed back to clinicians both how well they're measuring those outcomes. Are they being used consistently with all of their clients with spinal cord injury? It also helps to target areas where more clinical training might be needed. It allows hospitals to evaluate the impact of new equipment or devices or therapies that they may be using. So, for example, if a rehab hospital starts to use an exoskeleton for some of their clients, it gives them an objective way to know if it's making an impact in terms of recovery for those patients. We provide, you can see on the slide here, pictures of, these are clinical reports that go out to clinicians at all of the hospitals twice a year. And this really offers each hospital the ability to compare how they're doing and how clients with spinal cord injury coming through their hospitals are doing compared to other sites across the country. And one of the goals that we have at Praxis is really to help ensure that no matter where in Canada you have a spinal cord injury, you receive the same best care. The other thing that having this information in the registry does is it allows us to pool the information from all of the hospitals to start to answer some of those important questions. And Suzanne spoke a little bit earlier about how this can be a challenge in spinal cord injury unless you can kind of bring data together from a large number of hospitals. So one example in terms of that pooling data is in terms of the Standing and Walking Assessment Tool, or SWOT, the physiotherapists and researchers had the question of, during inpatient rehab, what's impacting the amount of standing and walking functional recovery a person is having after their traumatic cord injury? And so we were able to use the national RHSCIR data and work with that group to determine that, of course, the level and severity of injury to the spinal cord makes a difference to how much individuals are recovering in their standing and walking function. Also, the length of time they're spending in inpatient rehab makes a difference. And one of the interesting things we found is that which inpatient rehab hospital a person went to had a significant impact on how much standing and walking functional gain they were making. And so we wanted to really take that piece and as a group, there's a Canadian group looking into this. There's a new project underway looking at what's different, what's happening differently between these hospitals that might be impacting the amount of improvement people with spinal cord injury are getting in terms of standing and walking. So again, this is just an example of some of the ways that we're using and applying this RHSCIR data. And with that, I will hand it off to Dr. Colleen O'Connell from the Stan Cassidy Center for Rehab.
All right. Just did my video come up or?
Yes, all good, Colleen. We can see and hear you. Great.
Okay, I can't see myself, so I don't know where I am anyway. And so Suzanne, I think you're going to be advancing my slides, correct?
Yes, that's right.
All right, super. So thanks everyone for asking me to come and present. I apologize, I'm sitting in my car in a parking lot between meetings. So this is, hopefully you guys can see and hear me okay. I'm a physical medicine and rehabilitation physician. I'm at the Stan Cassidy Center for Rehabilitation in Fredericton, New Brunswick. And we've been a member of the RHSCIR team and a member of the registry. We're one of the later groups to join on. I think we started in 2011. Next slide. So our province, we're really quite small, and you know, our population in New Brunswick is less than 1 million people, and we can, within our province, we have our one spinal cord rehabilitation center, and we might consider ourselves really to be, in a way, you know, the big fish, but in a really small pond. But when it comes to looking at how we fit in nationally or even internationally, in effect, we really are a small fish in a very big pond. And next slide. What we needed to do in order to really promote ourselves and ensure that what we're doing was evidence-based practice. And an evidence-based practice is what we all aspire to as doctors, as therapists, as nurses, to have the best possible treatments for our patients and to have the best possible outcomes. And an evidence-based practice is influenced by not just our skills as clinicians in our experience, which we felt were pretty good, but also by our patient values and preferences, which we're okay at, but we knew we could do much better. But where we really needed to help and participate in was getting that best research evidence available. Now, we being a smaller center and not necessarily and not necessarily having a direct academic association. So we think about research being done by institutions that are university based. And where many of our clinicians, myself included, we might have university appointments, our facility in New Brunswick was not necessarily an academic or university based facility. So we needed to do a lot of convincing about the importance of this evidence-based practice and participating in research. And being able to participate in this national registry was really our foot in the door to becoming not just a big fish in a small pond, but having our place in that big pond. And this slide you see here was actually part of our presentation to our entire hospital, including the policymakers and the administration, about why we needed to be part of this registry, which we were able to do in 2011. So what it's meant for us as an institution is we've been able to, next slide, please. We've been able to use some of that data that was just presented to you, so that those reports that come to us quarterly and annually lets us measure ourselves up against what's happening in the rest of the country. It helps us be better at what we do, making sure that we're using our standard outcome measures and that our staff have been trained in those outcome measures. And I think that this then imparts confidence for our patients. They know that we're part of what's happening nationally, that the care that they receive here in New Brunswick is going to be comparable to the care that they might receive in the big city of Toronto or Vancouver, for instance. So it also allows us to be able to keep on top of this. It also allows us to recognize what the important influences are on the nature of injuries that we see, and therefore help us to be better at preventing and managing those outcomes and resourcing our services. The importance of research, next slide, please, is more though than just the stats that we get to help ourselves be better. It was mentioned about opening the doors to having new equipment that can help us with some of our research activities and as well integrate well with our clinical care. We've been able to introduce the novel therapy to some of our patients because of our participation in this types of research. And all of our clinical staff now have acquired new skills that they can put into practice directly and immediately with our patients. Next slide, please. We also have improved overall our clinical teams in their what we call their research literacy. They're able to read what's being published in the literature, process that, and tease out what's important to put in place into our own practice, and therefore adopt some of those early research findings into our clinical practice. And I think what's most exciting at our center is it's created this real culture of inquiry and allowed us to critically appraise our own practice. And together we've all been working very hard now at taking some of those research findings, coming up with our own questions and putting them into practice. This is the entirety of our physiotherapy team, for instance, at our center, all working now to learn how to use FES cycling with our patients on activity restoration, activity-based therapies. And also we've done our own independent projects looking at this modality on exercise and as well on spasticity and pain management. Next slide, please. It's also enabled us as well to strengthen both our existing collaborations, maybe locally, but also build new networks and new collaborations nationally and internationally. A couple of really important ones have been our center's participation on the Canadian best practice recommendations. It's allowed us, and this is strongly with Praxis support, to more formalize a network of all of our Atlantic provinces with regards to spinal cord injury, and that includes persons with lived experience, researchers, administrators, clinicians, and community advocates. And it's opened the door for our participation in some of the national efforts around spinal cord injury quality improvement initiatives and best practice implementation. Next slide, please. The standing and walking assessments have already been presented to you by Kristen, and our team has been really happy to be right in on the ground with this and participating. And in fact, some of our team members are some of those who help peer mentor and do training in these walking measures. And we've incorporated these walking measures into our own practice. Additionally, participating in some of the best practice initiatives and joining a spinal cord knowledge mobilization network, which then evolved to the consortium, allowed us as well to do some of our own work and own evaluation of how good we're doing, for instance, in pain practice. We were able to evaluate our outcomes, and we included persons with lived experience in this evaluation, taking their considerations and insights, and then came up with guidelines to help improve our own practice. Now, what I'd like to take you through just a couple of minutes is a very specific example of how participation in RHSCIR and the support through Praxis, through not just registry, but how the registries enabled our entire research culture to improve here. And that was with the formation of our spinal cord injury network of the Atlantic provinces. We held a regional Atlantic meeting, next slide please, and did an evaluation with the input, as I mentioned, from all of those stakeholders. And we then, as a group, identified those strengths along the pillars of care, of community, and along research, identifying where our strengths were in each of these pillars. And then as well at the same time, next slide, please, not trying to target, oh, this is what we do wrong, but looking at what our priority needs are as a community along the areas of care, community, and research. And what we did then is prioritize those for our next stages of research and work that we're doing. So for instance, we recognize, particularly in the areas of psychological support and emotional well-being, that we had priority needs, not just in care and not just in community, but as well within our research. And so this started us off on a very directed project. Next slide, please. Where we used some of the RHSCIR national data, where actually was just presented, 2 out of every five individuals presenting with mood impairments and the prevalence of anxiety and depression. And looking at rural and urban distribution of that. So armed with those statistics, and then recognizing that the characteristics of injury that we're already collecting in our RHSCIR database, the types of injury, gender distributions, then looking at the secondary complications that occur during hospitalization, as well as community follow-up, and the fact that we're already gathering information about anxiety, mood, and how people are functioning in terms of quality of life and mood on follow-up. We were nicely positioned then to do an evaluation of how our own practice in a deal, next slide please, in dealing with mental health issues. So at our center, we look at our typical practices. We assess people when they get admitted to rehab, we monitor their mood during rehab, and we offer psychological support for those individuals where we've identified an issue. And so we were then able to do sort of an analysis of our outcomes, and we used the RHSCIR data for this. This was already being collected, so we were able to look retrospectively and then move prospectively. So we identified that, we still had numbers of patients who were reporting issues with regards to their life satisfaction, anxiety and depression, but in general, people were doing better on discharge than on admission. But then, and then we looked at that though across the board, and we found that the numbers are still concerning, right? 1/4 of people who still had anxiety at discharge, 30% of individuals who still reported sort of a poor life satisfaction, and then as well 10% with depression issues on discharge. Then importantly, because we had the data from RHSCIR, we were able to go in and actually look at those community follow-ups, and we could extract that population of RHSCIR participants and see, well, what's really happening once they get home at that 9, 18 month and 2-year period. And from that, then we looked at that data and gave ourselves a report card. And so that report card, next slide please, gave us some really insightful information. We did excellent at following patients throughout their rehabilitation. We did excellent on documenting with defined measures on their mood and anxiety and depression. But wow, when they got back into the community, patients were still reporting some significant symptoms, and their discharge status did not predict what those were. And so what that told us is that we need to do a better job of making sure that we follow through on those community follow-ups. And so part of that then, next slide please, is the importance around using some of that information and support from this consortium that we're already a member of. And so one of the consortium key indicators is on that emotional health and well-being. And so with that community, we're now looking at very important implementation aspects of best practice that includes that community follow-up at that 18-month marks, so that we're not going to miss those individuals, and then that hopefully will improve our overall practice. And I just really want to point out that we have our implementation teams targeting this, which are inclusive of persons with lived experience. So the entirety of our research program now is so intertwined with our clinical day-to-day work, our clinical teams, as well as our persons with those lived experience. The next slide, please. And so, participating in the registry has been extremely pivotal with that praxis support for giving us this very broad and rich research participation throughout our network. And I really, I'd like to finish off with just saying, we really could not have done it without praxis support. And the registry has been key from the beginning and continues to inform what we do. So thank you.
Thank you so much, Colleen.
And sorry, Suzanne, I had to keep giving you clues. I'm so used to just flipping as I talk. I'm not used to sort of saying, oh, turn now.
So I guess some of them. And thanks to Colleen. And I just want to spend the last few minutes talking about some future directions for RHSCIR. So we very much, from everything that we've discussed today and shown you today, we very much see the value in continuing to support the continued activities as we do now, but also we would like to hone in and focus on some additional priorities. So one of these is incorporating provincial priorities into the registry more. And as Colleen mentioned in her talk, each province have their own priorities, their own network of individuals interested in spinal cord injury treatment and outcomes. And so we would like to be able to be more flexible with the registry, being able to bring in more specific data that is important to particular provinces and being able to report back and use that data locally. We currently have a data access process, as we explained, and while retaining the security and how protected this process is, we would like to make it easier and quicker for people to access and use the data that is in the database. We've currently used RHSCIR as a framework to support other studies and projects, and we'd like to continue to do that and enhance that as well. So in specifically answering specific research questions or questions around best practice, and adding additional data to the data that's already collected in the registry and being able to link that together. We've also started looking into collecting different types of data, such as imaging data and blood and serum marker data that can help predict neurological outcomes. And we'd also like to link these types of data together with the clinical data and the data that's collected from the participants themselves. And by having this broad set of data, we'll be able to more easily use advanced analytical techniques such as machine learning, where the data itself drives more predictive algorithms that can potentially help predict neurological outcomes and better and customized treatments for individuals. As we mentioned before, a problem that can be common with SCI data is not having large enough data in order to answer questions and get really answers that make sense for the data that we have. And so we'd like to continue to standardize what we collect in the registry as a core data set to be able to pool data with other international registries, enable to create a bigger pool of data and therefore answer research questions better, and also look at the differences between countries. And another thing that we would like to do is revisit the governance of the registry and how the data is governed, and make sure that this is centered around people with lived experience and their priorities and input is taken into data use. Additionally, we want to have we're going to start a project to look at making sure that any data that's collected on Indigenous individuals is really governed and owned by the Indigenous people themselves. And on that note, I'd like to introduce Richard Peter, who's our Indigenous Peoples Liaison at Praxis, and ask him for his thoughts to finish the meeting.
Hi there, thanks, Suzanne. Yeah, just to give a bit more info for myself, I'm a Plex member. I was actually injured about 45 years ago, so I've got a bit of experience in that area. And how I came upon this position, not that I was searching it out, but actually my previous job working at GF Strong, worked with the SCI peers at GF. We were doing an education session, and John Trineski, who works with Praxis, came and gave a quick presentation. And throughout the presentation, I asked John what they were doing in regards to the Indigenous population, both on and off reserve, and that sort of stumped him. That was the first time I'd ever seen John speechless. And that's where this position evolved. And that was definitely a bit of a challenge for myself. I said, yes, I definitely enjoy taking on this role, as this was the question that I did bring forward. So it's been a bit of a challenge in regards to we started just before COVID, but it's been very easy just with getting the ball going and sort of getting everything rolling. I first started off just learning a bit more of who our partners are, and also then finding out more of the different areas, as John did ask me about that too. And I said, well, we can start just about anywhere. So making a lot more partners and meeting a lot more stakeholders that are involved. And we first finally, just a little while ago, had our first Indigenous SCI gathering hosted by Praxis here in Vancouver. And through that was mainly a quick study just to get a bit more information, find a few more members here locally. And our next steps are now going to work in partnership with, we had Vancouver Coastal Health and their Indigenous researchers, and also partnered up with Wakavines, who is we're going to partner up with and host a larger BC-wide session that's coming up middle next year. And then also we're going to plan on hosting many more sessions across Canada. And so just to get more of information with info to help benefit RHSCIR too. Because I know we've got a few pockets of information with Indigenous populations, but I always say we want to add more info and also get more peers to come out and stay involved. So I know we're sort of short on time, but yeah, that's sort of the gist of what I'm doing, and it's been really good to help, branch off with Praxis and go into some more areas of, as I always say, is sort of closing the gap, to try to open up more doors between the Indigenous population and research. As I know, history has shown that hasn't always been a safe journey, and so that's where I want to try to come back and sort of close those gaps and make sure that we still can get more participation, and because it, as discussed earlier, it's all about quality of life, and hopefully that'll improve things in the future. Thank you very much. Back to you, Suzanne.
Awesome. Thank you, Richard. And that concludes what we'd like to talk about today. So thank you everyone for joining us. And I hope that you found that informative and useful and understandable. And we'd like to continue to do these types of presentations more frequently. And thanks. If you have a question, and you haven't had an opportunity to ask in the chat, there's an email there that you can contact us on. We can answer any questions or provide any information. And we'd like to send out just a survey through the email for those registered today, and ask for your opinion on the presentation and what you'd like to see in the future. So thank you, everybody. That's it for today.